Thank you, Casey. During our discussion today, I will touch on a few discussion points. Firstly, I will share with you the history of the RVU study. Then we'll look at the approaches to calculate an RVU. We'll look at the process to finalize these RVU study. We'll then look at the RVU study specifically and the structure around that. And then lastly, Nevada will take us through the SADA survey specifically. Firstly, in 2009, there was a study commissioned to the Northwest University. This study, the PRELA study, calculated or attempted to calculate the RVU values. This was submitted to the Department of Health. However, the Department of Health did not approve this due to various reasons. One of the reasons being that the survey sample was not representative of all the dentists. There was a few surveys received from specialists and also a few received from the dental practitioners. Secondly, we know that the codes that was applicable in 2009 is not necessarily the same codes that are still applicable in 2017 and 18. So that study was not finalized. However, we do have the results of that study, and that study will be used in the current survey as well. The RVU study was again commissioned in 2017. Towards the second half of last year, you would have received an electronic distribution of this survey. However, it soon became evident that that survey had to be redesigned and rethought. I will explain a little bit later on what the exact changes is from the current survey compared to that survey. So when we look at the process now going forward, this presentation is to inform the data collection of this project plan. We're conducting the survey and we're literally collecting data. From here onwards, we will collate all the data and we will construct a draft tariff value. This draft tariff value will then be presented to the various stakeholders. The real work will then actually start. There will be a back and forth discussion on this draft tariff value until there's a tariff value on the table that everyone is comfortable with, that is reasonable and representative. We will not go away, collate all the data, simply take an average and then put the tariff value on the table to be approved. That will not be the case. There will be a lot of stakeholder discussion following this data collection phase. When we look at the different approaches to calculate an RVU and to conduct an RVU survey, there is various international research on how this can be done. The approach taken for this survey was that there will be a combination of all the various approaches on the table. And the reason for that is that it's very important to have a practical, easy to understand survey, however, to still include the information that we ultimately need to calculate this RVU value. When you look at the structure of this survey or this study, there's basically two parts. The one is the relative value for work, which is the responsibility factors. That is the questionnaire and the survey that you currently have and that you are requested to respond to. In the previous electronically distributed survey, there was a financial information component as well. However, we do realize that this is sensitive information and we've therefore not included it in the survey that is distributed now. In order to calculate the relative value unit and then get that into a monetary value, we do need financial information. And therefore, we're requesting that if you are willing to provide your financial information, please let us know. We will then sign a non-disclosure agreement with you for you to provide us with that financial information. SADA will never see that information and no one will have access to that information. We will only use that to convert the relative value for work units into a monetary value. I mentioned that it's important to have an easy and practical yet credible approach to an RVU survey. If we would have included all the various components that can form part of a relative value unit, we would have probably have something like 18 columns on that sheet in front of you. Specifically, if I can take an example, if we had to look at the special equipment use, we would have requested the cost of the special equipment. Then we would have asked, how do you allocate the use of that equipment across the various procedure codes? We then had to look at the depreciation over time to ultimately include that component. So that is one example, and the example that you see on the screen of how the relative value study would have looked if we had to include all the different components that can possibly contribute towards a relative value for work unit. One other example is risk and stress. We chose to combine the risk and stress. However, technically there's risk to the dentist, risk to the patient, stress to the dentist and stress to the patient. However, having a survey with so many columns will just be totally impractical. I will take you through the SADA specific survey and mainly the structure, where I'll hand over to Nevada then to take you through examples of the survey and how you need to respond to this. Firstly, you need to respond by allocating a number between 0 and 8 to the specific procedure codes for the specific responsibility factors. Again, Nevada will take us through the detailed example. I just want to explain the relativity of this responsibility factors and the relative value for work units. It is important to keep consistent when answering all the different procedure codes questions. The relativity in these codes and amongst the surveys are actually between the codes and not necessarily between the various responses received. I will give you an example. If dentist 1 believes that code A, he needs to score a 2. Code B, he needs to score a 4. The next dentist next to him might believe that for code A, they need to score a 4, and for code B, they need to score a 8. The relativity between the two codes are exactly the same, even though the codes across the various dentists or responses differ. So again, it is important to respond with consistency between the procedure codes and not necessarily being consistent between respondents. I will now hand over to Nevada to give you an example of the survey in all the different columns.
Thank you, Talisa. So I'm going to take you through specific examples on how to actually complete the survey. So if you look at the survey, your first column would be the codes, so your procedure codes. The second one is your descriptors, and we're going to dive straight into use of special equipment. So what that means is what equipment is required for you to do that procedure that would not be contained in a standard GP practice. If I can give you some examples. An X-ray machine is contained in every GP practice. That would be standard. A sensor would be special equipment. When you're doing interproximal caries restorations, your Toffel-Myers or your Sequeland matrix bands, those would be considered standard equipment. A more advanced system like a Palodent system would be considered special equipment. Some other examples, if you have the wand, your delivery of local anesthetic is via wand, that would be special equipment. The apex locator would be special equipment. An endomotor would be special equipment. In addition to that, your electric motor would be special equipment. Your standard handpiece would be standard equipment. Something like a CREC machine or a CAD/CAM machine would be considered special equipment. So we expect you to just tick a yes or no on that column for which procedures require you to use any special equipment. You don't need to list the actual equipment that you're using, just a yes or no would do. The next column refers to procedure time. We want you to rate in minutes how long it takes you to do a procedure on average. So we're looking at the average patient, not the exceptional that is specifically difficult for that particular day and has taken you a lot longer than it would usually. We're also not considering the extraction on a really mobile tooth that takes you a second to do. We want the average, 9 out of 10 times. If you're doing that particular procedure, how long does it take you to do that procedure? It's important to strip out things like your local anesthetic because that is reported under its own separate code. You also need to strip out the time that it would take you to put on your gloves and mask and any infection control procedures that you would do in your operatory area. I think it's important when you're doing procedure time that you understand that your procedures that require multi-visit treatments like dentures, like your crown and bridge as well, you need to consider every aspect of the procedure. So you're only reporting one code, but you're probably seeing the patient 4 or 5 times, and you need to account for each of those appointments. How much time do you spend at each appointment in total for that procedure? When you're looking at things like your code 8101 or consultation, it needs to include both the charting of the teeth It needs to include your treatment plan. It needs to include your discussion with the patient on informed consent and informed financial consent. It needs to include the discussion with the patient on any complications, on alternative treatment options, and the patient's approval of whatever your treatment plan is. So what you might start off thinking is 5 minutes, you might find is more like 20 minutes, and we want you to just really consider every aspect of the descriptor within each of these codes before you answer how many minutes it takes you to do the procedure. Okay, then we move on to experience and knowledge. So this column, the next 4 columns actually, your experience, your judgment, your skill, and the risk column, all feed into the responsibility factor aspect of the RVU. So these columns all need to be rated on a scale from 0 to 8, with 0 being the least and 8 being the most difficult, or whatever it may be. So your experience and knowledge, we want you to answer this in referring to how much or what level of your experience is required for you to do a particular procedure. So we're not looking for what you think is the level of experience required to do any particular procedure. It's how much of your experience do you have to tap into to do a procedure. So if I can give you an example, if you're very, very experienced at doing extractions, for example, you might find that you've done so many of them that the level of experience that you need to tap into to do one is actually very, very low. By the same token, if we're looking in the same spectrum of procedure codes, we now look at, say, an 8213 or an 8937, which is a surgical removal of a tooth or surgical removal of roots. You might find that this is a lot more difficult for you and you don't do it as often, so you need to tap into more of your experience. And then if you compare that now to an impacted wisdom, for example, and you might find that you very rarely, if ever, do one, and that might be the maximum of your experience is required for you to actually do that procedure. So I find that it helps to group similar procedures within similar categories so you can compare them to one another. So I've given you already the example amongst the extractions and surgicals. You can also do the same thing amongst your 1 surface, 2 surface, 3 surface fillings, or 1 tooth partial denture, up to a 3 tooth partial denture, up to a 5 tooth, etc., etc. And that's how you would estimate that particular column. So the next column refers to your judgment and your mental effort, and that's the cognitive aspect of this, and what level of thinking does it require for you to do a procedure. So again, you will find that an anterior, straightforward, single canal, root canal that you need to do, you might not need to think as much about it because you're not anticipating as many complications. Your x-ray is very clear, it's a wide open canal, there's no calcifications within it, there's nothing for you to really think about. But then if you compare that to a upper premolar where you're expecting it to have 2 canals and you now discover there's a 3rd canal and that 3rd canal is now curved, or there's a calcification within it, there's a lot more thinking involved as you're physically doing the procedure. You would have to put a lot more mental effort into it. So that's what we want you to reflect on that scale from 0 to 8. What level of thought, what level of cognitive effort do you have to put into doing these procedures? Your next column is your skill and your physical effort. So that really is self-explanatory. It's a skill that's required for you to do a procedure. It's a skill in your hands. Things that you do very frequently and very often might be very low on your level of skill for you to actually do the procedure. And those procedures that you don't do as frequently and that you're not as experienced at might require a lot more of your skill for you to do the procedure. So again, on a level 0 to 8, keeping similar procedures within similar categories, compare them amongst each other. And your last column is risk and stress. So again, you've got to remember that it's risk to you, risk to the patient, stress to you as the provider, and stress to the patient. And again, on a level of 0 to 8, what level, combine those factors, does it take for you to do a certain procedure? You might find that a consultation is really limited risk or stress to either you or the patient. But then if you're doing an implant, for example, the level of stress and risk is a lot higher because now you have to worry about the complication rates. You have to worry about the patient's compliance thereafter to make sure that there's no failure of this. So this is what we're looking at. What level on 0 to 8? Again, keeping similar procedures within similar categories and keeping the relevance between, or the relativity between each other. So if there are any other questions, we are happy to respond to them, and you're more than welcome to contact us on email address zasada@deloitte.co.za. Thank you for your willingness to participate, and we look forward to seeing your responses. Just bear in mind, when you're responding to the codes, you only need to respond to those procedures that you actually do in your practice. And one last final reminder that none of this RVU will mean anything without the assistance of your financial information as well. It is key for us to have relevant information on what it costs to run a practice. So we urge you to send through your financial information to zasada@deloitte.co.za. Thank you.